I would like to welcome everyone to this afternoon's scientific session, and a special hello to all our friends on WebEx who are joining our webinar. We are very excited to host this session via WebEx today. Our speakers today on the subject of treatment adherence are Dr. Kristen Reichert from Johns Hopkins University, Dr. Marilyn McDonald from Dalhousie University, and Dr. Yves Berthiaume from the University of Montreal. In the efforts of saving time, I ask that you refer to our speakers' biographies in your AGM handbook. And we also ask that you save all questions till the end of the session. And for those who are joining us on WebEx, please feel free to use the chat box. I'd like to introduce Dr. Kristen Reichert.
Thank you very much. I appreciate being invited to speak with you today. I'm going to be talking about the results of two adherence trials, the BALANCE study, which was a single-center study that I conducted at Johns Hopkins, and then the iCare study, which I was co-PIs with Alexandra Quintner on, that was done at 18 different care centers around the United States. It's always hard to know how much the clinical stuff to put versus the hard data, so I'm going to try and balance it, so I apologize. Hopefully there's a slide for everyone. So these are my disclosures. I do a little bit of consulting, and my funding is from CF Foundation in the U.S. and NIH. So first I want to point out why we're here today. We're talking about adherence, and this slide shows adherence across different ages and then overall. Actually, this is just age, sorry. And what you can see is that each age group, so there's children, adolescents, emerging adults, which is 18 to 25, young adults, which is 25 to 35, and then those individuals over 36. And what you can see is adherence ranges from 0 to 100, no matter the age. But what we also see is that adherence is pretty good in children, and it declines with age. I call that when you get your momectomy. And we always say adolescents, oh, those adolescents, they're so hard. The young adults are actually worse. They just don't show up to clinic. So they don't affect care team perhaps as much, but I think any parent in the audience would agree that the young adult is perhaps a little challenging as well. There's a lot happening in young adulthood and adolescence, a lot of changes, and change is always hard, and change makes it hard to stick to habits and routines. But adherence is really important, and we showed this by looking both at the need for IV antibiotics and at lung function. And the bar graphs show the adherence levels of people who had different numbers of exacerbations over the course of 1 year. And the results showed that anybody who needed one or more courses of IV antibiotics had lower adherence over the course of that same year. And what you can see is the individuals who have, no pointers because we're on WebEx, you can't do pointers on WebEx. Anyone who had over 3 or more exacerbations, no one had adherence that was over 80%. But I want to also point out that in the 0 group, adherence ranged from 0 to 100. So even if you did nothing, some people are just fine. And therein lies one of the problems is some people can be just fine without doing anything. But there are also individuals who have 100% and are really working very hard. But there's also high adherence among those who have 1 or 2 exacerbations. So it's not a perfect correlation between health outcomes and adherence. The lung function data, to me, is interesting. So again, this is a very small sample. It's only about 100 individuals, and it was only 1 year of observation. The slopes are not significantly different from each other, but what you'll see is at baseline, those who had 80% or higher adherence had the highest adherence and did not lose lung function over the course of a year. And those who had moderate adherence, the 50 to 80%, lost almost 2% of lung function over the year. And those who had adherence less than 50% started out the lowest and stayed the lowest. And so there is some clinical indication that adherence matters to lung function. And this is important data because patients really and families all ask, does it really make a difference? Does it make a difference if I skip the weekend? When you skip the weekend, you're at 73% adherence just from the get-go. And so that puts you in that medium middle group. So yes, this is very helpful data to start a conversation with families. So the balance study. This was a study comparing two active interventions. So it's a comparative effectiveness study. It's not saying if we do nothing, does doing something help. It's saying if we do what is in the psychology world is considered pretty standard, which is problem solving, but compare that to something called motivational interviewing, does that make a difference? Does it affect their adherence, and does it affect health outcomes? Because again, I have no interest in making somebody take more medicine if it doesn't also make them healthier. So that should sort of be our mantra. We don't ask them to do more just for the sake of doing more. And so this was a two-group randomized trial where it was stratified by age. It included individuals age 16 and higher because it was an individual-directed intervention, so we didn't want to have to include parents, and we felt that by age 16, they should be taking on more responsibility for their own health. We can play motivational interviewing to problem solving, and I'll explain those later on. The sessions were a face-to-face at a regular clinic visit, and then everything else was done by phone, so there was no need to do extra visits, because that came out very clear in some of our qualitative work before doing this is, please don't take any more of my time. And thus, we also did web-based surveys versus phone-based or having them come in. And we extracted their health outcomes from their medical record, again, so that they didn't have to do more testing. And then for our adherence measure, we used pharmacy refill data, because right now there's no electronic monitor that can do a date and time stamp of nebulizer use. So at the time, this was the best possible objective measure. And if I had infinite amount of time, I'd show you all my fun slides about why self-report is not particularly accurate, because I'm a geek about that. So comparing the two interventions. So I'll start with problem solving first. Problem solving is directive, it's highly structured. It's not you're mean, you're bossy, but you have a really strict plan. In my next slide, I'll show you that. But it assumes that non-adherence is because you just don't have the knowledge or skills you need to be adherent. So this is sort of what most healthcare providers do, right? If I could just get them to understand why it's important, they would do it. So this is a little bit of that, but also acknowledges that there might be some barriers, and if we could just figure out how to overcome that barrier, all would be good. Motivational interviewing, on the other hand, is a much more collaborative, patient-centered approach. The perception of, from the perspective of MI, the failure to change behavior is due to some ambivalence. There's some reason for not changing. And to see if that reason's pretty clear, it takes a whole lot of time. So there's a counterbalance to doing it versus not doing it. And so instead of me telling a person why they should be doing it, we try to elicit from the person their personal reasons for wanting to do it. And to the surprise of many MDs, better lung function scores rarely anybody's reason for taking their medicine every day. More often than not, it's, I want my parents to allow me to go away to college. I want to be able to make it to prom this year. I want to be more successful at work and not have to miss work so often. I got fired because I missed too many days. You know, there are many personal reasons that we try to elicit and then use that to get people motivated and ready to do the change themselves. Because most people are pretty smart, and they can figure out for themselves what they need to do once they've decided they really want to change. So it's very autonomy supportive. That means it's your choice. You do what you want to do. I'm trying to help guide you and make sure you have the information and the skill set to do it. So they're very different flavor, right? One's very do what I say. One is what do you want to do? Problem solving I'm going to get into a little more because the eye care also did problem solving, and so I wanted you to understand, I think every healthcare professional, every family feels that they do problem solving, and we all do in a sort of a generic way, but when we do these interventions, it's very structured. It's personalized in that in defining the problem, that is based on the person's selection of the problem, and the solutions are collaboratively generated, but you always follow these 5 steps. So for the balance study, like I said, it was age 16 and up. They had to be prescribed 1 chronic pulmonary medication because otherwise we couldn't measure adherence. And they had to be a regular patient at Johns Hopkins, not someone coming in for a quick consult. There are very few exclusion criteria. You know, this is not like one of the drug trials where they have a big long list. We wanted all comers. So our sample, we recruited 128 individuals. The mean age was 29 years old. It was half male, half female, primarily Caucasian. A very small proportion had public health as their only source of insurance. 82% were pancreatic insufficient. I think this reflects that Hopkins sees a lot of late diagnoses who are pancreatic sufficient. 15% had CFRD. Lung function was in the moderate to mild range, but we definitely had a broad range as with BMI. So it was a fairly healthy group of adults. Medication adherence. So did our intervention actually change medication adherence? The answer is sadly no. We didn't. And but I think for me, this is part of my soapbox of pharmacy refill data actually takes a year, because think about how often you pick up a prescription. At most, it's 12 data points. For alternating antibiotics, it's only 6 data points. So it's very hard to move that dial. And some behavior change happens perhaps right after a session, and so adherence peaks, and then it tapers off. And so we can't really figure out if during active intervention, those first 6 months, did we change behavior when we were talking to them regularly. And we talked to them about every 2 to 3 weeks. We had 9 sessions in total, and most individuals completed all of those sessions. So we did not see change in adherence. And I'm ruminating on this because we did see change in health outcome. So for lung function, over the course of a year, the problem-solving group, which is the blue line, had a decline of lung function about 3.9, which is typically what's seen in adults with CF, whereas the motivational interviewing group only had a decline of about 1.9. And so that difference was about 1.84. That's a pretty impactful outcome. It's fairly similar to some therapies. So if we could actually we had to have done something, I think. We just couldn't measure what that was because the pharmacy refill data wasn't particularly sensitive to that. But we did see lung function change. We did not see any BMI change. And this makes sense to me because we did not focus on nutrition. We focused on medication adherence. And so one would not necessarily expect nutrition to change by improving medication adherence. Now I'm going to transition to the eye care study. This was funded by a partnership with the Cystic Fibrosis Foundation, Genentech, and Novartis. Like I said, Alexandra Quintner was the co-PI, and there were 18 care centers around the country. And I have to give a big shout out to those care centers because we gave them very little money to do this study, and they rocked it. Our hypothesis was slightly different. So the BALANCE study was focused on, if we do this intervention perfectly, can we get changes in outcome? The eye care was more, we know problem solving works when it's done in very controlled settings by highly trained psychologists, but most of us can't have a highly trained psychologist in our clinic. There's not enough mental health professionals to be there for everybody. So can we train the healthcare team, the CF team, to do problem solving at a regular clinic visit, so it's just built into the clinic as part of regular clinical care. So that was our goal. We were training the care teams to provide this versus us providing it outside of regular care. So again, the same hypothesis, can we change adherence, and does it improve health outcomes? So this was a clustered trial in that once you train a care team member, you can't untrain them, so you can't randomize at the person level. So each center got randomized and then fully trained. And it was a waitlist control because we didn't want the care teams that were put in the control group who got nothing, standard care, to feel not particularly happy that they're doing all this work and not getting trained. So they got trained in year 2. I'm showing you the results up to the end of year 1. Again, pharmacy records were our primary outcome. Both studies started around the same time, so I didn't know what I now know about pharmacy records. And we did very bare-bone patient surveys, knowledge, skills, and quality of life in-clinic surveys, computer-based, at baseline 12 and 24 months. And then we worked with the CF Foundation to get their health records from the CF registry. So the care teams didn't have to do anything besides prove to us that we had permission to get the data from the CF Foundation. Again, this was a very pragmatic trial and an example of an effectiveness study rather than efficacy study. This study enrolled individuals aged 11 to 20, so we focused on those teenagers. They again had to be prescribed a pulmonary medication. They had to have data being entered into the registry. We didn't want them moving clinics in the 2 years because we wanted them to be available for data collection. Some rule about satellite clinics where some centers in the states only go to satellite clinic every month or so, when we really wanted to try and capture families that were going to have up to or more than 4 clinic visits. We felt that at least 4 clinic visits would be necessary. And on the lung transplant list was more because we felt that they would be transplanted before we were able to collect all the outcome data. They could be listed and still join the study. So these individuals are, like when I said the care teams rocked it, they did. We enrolled 607. So when I look at this age group in the CF registry, that's a big chunk of people from the registry. It's about 5% of all people with CF in this age range joined this particular one study. So again, I can't say enough about the wonderful work of the care team. On average, they were about 15 years old, which is right smack in the middle. Caucasian, female, 30%, so a higher proportion than the Hopkins sample, had public insurance as their primary source of health insurance. They were fairly healthy with a mean FEV1 of 84 and a BMI percentile of 47. But again, a lot of variability across the sample. Yet again, we saw no difference in adherence. You can see this funky pop-up at baseline. I put the ends in there so you can see. We actually had a lot of trouble getting pharmacy refill data. There are a lot of companies out there that tell you that they can get you medication adherence data, and they can't. I've worked with a lot of them now. We ended up doing it the old-fashioned way of getting a consent form and calling every single pharmacy and asking them. So a lot of staff worked on this to get this data. We were a little concerned that people who had baseline data, so that all happened about midway through the study. So we had to reconsent anyone. So anybody who withdrew because they'd moved, et cetera, we couldn't reconsent. And then some pharmacies only keep data for 1 year, and then they toss it. And so we didn't get a full amount of baseline. So we only have baseline data for about half our sample. When we only look at that, the half that we have baseline data, the graphs look exactly the same. So there's not really any bias in the fact of who had baseline data. I cannot explain why there's a 15-20% drop in adherence from 1 year to the next. I am hoping it's just something funky with our data. We're still looking at it, but it is quite odd. I will say that for problem solving in this intervention, they did not need to focus on medication adherence. They could work on nutrition or airway clearance, and in fact, most did choose to do something other than medication adherence. And that just points to how much more complicated it is to even do, how much more labor-intensive and cognitively demanding nutrition and airway clearance are. But again, even though we don't see these adherence changes, we are seeing differences in lung function. They're tiny. I don't particularly want to overinterpret them. I've been ruminating on them. We just got this data all completed about 2 days ago, so still trying to think what I think this means. It's a p-value, so it means I get a publication. I don't know if that means it's clinically important. It is a very small percent, but I think anything we can do, and again, this is not a particularly challenging, complex intervention, and the people we trained, we did a lot of fidelity and supervision training with them, and they were very able to learn those skills. They picked them up quite fast, so I think this is something that could get incorporated. We did see a change in BMI percentile. Again, I think this reflects the fact that they could problem solve on nutrition, and so that was a pretty significant difference that favored the intervention group. Okay, so my conclusion, I think all the interventions were really well received. At the end of each intervention, we always do some open-ended qualitative questions. What do you think about this? The iCare study, we actually did a fairly long satisfaction survey about general satisfaction with their CF care and about the intervention itself. And the kids' statements were probably the most profound of the care team was finally looking at me and not my mom. I was finally a person in the room. I may not have done it forever, but I did give it a try because it was an idea I came up with. So I think the intervention resonated and helped build the relationship with the care team. The care team called the iCare study, one care team called it the eye-opener study. In addition to problem solving, they did some skills training, so they had everybody bring in their equipment, and people realized vests were too small, they were being worn backwards, they were broken, things were filthy. I mean, it was amazing. Apparently one little brother, when the vest got pulled out, said, "What is that?" Which clearly indicates he'd never seen the vest before, which means it probably was never used before. So I think the care teams found it very rewarding as well. I think the number, we've talked with the care teams about the challenges, and it's really finding the time to fit it in. I think people felt that it was a worthy intervention. It was, how do we just incorporate this into everything we're being asked to cover in a clinic visit and not make the visit last forever, because neither families nor care teams want visits to last forever. Again, I've talked about the concerns with using pharmacy refill data as an agent of change. We really do need objective measures. I've been working in concert with the CF Foundation in the States with PARI to try and develop a device that can electronically monitor nebulizer use. In the UK, there are some measures already out there, the AKITA and the INEB. It really is fantastic data to really show where people are struggling. Is it the morning? Is it the evening? In the Balance study, we gave their pharmacy refill adherence data, and people were amazed by the number, because you don't really, when you try to do your own number, you always think it's a little higher than it is, and when you put it out there, you're like, oh, I didn't realize that. Okay, maybe I'm not doing as, it feels like I do a lot, because again, doing 50% of your CF regimen is still, an hour or more a day, and so it feels like a lot. So I will say I'm always impressed when anybody can even do half of it, because I don't know I could even. But we really do need to think about how to do this, because it's a conversation starter. We don't have to play the game of I'm doing it, I'm not doing it, who's doing it, the doctor doesn't believe me when I tell them the truth. It's really just a good way to start the conversation where it needs to start. There's some positive results for health outcomes that adherence promotion interventions work. I think it's a little more impactful on lung function with motivational interviewing. I'm really excited about those results. And for BMI with the problem solving, we did not see any difference on health-related quality of life using the CFQR. But I think my big takeaway is I think we're finding things that work, but we really need to work on how can we make this more practical. The CF Foundation has funded an adherence consortium of 20 sites around the state that are going to work on this. Not only do we want to find the perfect thing that works, but the thing that's going to work might be less perfect, but be the thing that people are willing to do. So looking at technologies and truthfully some basic things like doctor-patient communication. How do we communicate? How supportive do individuals feel when they're at the clinic? Are there better, I think everybody works very hard to communicate well. Are there ways we can communicate even better? There's certain phrasings that could be used differently that will resonate stronger with individuals. That's about all I have for this one. I know I've kind of dabbled between the science and everything, so happy to do more specifics when we have the panel. Thank you.
Such interesting stuff. Thank you so much, Dr. Reichert. I'd like to introduce Dr. Marilyn McDonald.
Hello, everyone. Thank you for bringing me here. It's my pleasure. Okay, let's go. So as you can see from the title before you today, I'm actually in the process of doing this study. Towards the end of the presentation, there will be some very, very preliminary results, but I wanted to give you a little bit of flavor. So this study is about generating theory and generating theory to help us further understand self-management and, of course, adherence. This is what I plan to address with you. So the question guiding my study, how is adherence in medication management understood by adults? So note adults, because the study is strictly with adults, with CF, their family members, and healthcare professionals. The objectives of this study, and you'll see because it's a grounded theory study, I really want to capture the perceptions of adults with cystic fibrosis, family members, and healthcare professionals. And given that they're adults, they could be in a partnership. There may be a family member, whoever the individual is, that they indicate that assists them most with managing their CF. And it could be in some event, given that they're young adults, there may not be another individual in some instance. And in doing grounded theory, whatever your phenomenon of interest is, and in this case, it is adherence. And so in the process of doing this study, I want to find out what the main concern of those involved is related to adherence and what is it they do about it. And number 3, characterize the structures and processes that facilitate or impede adherence, and contribute to a definition. We have existing definitions, but I think we may be able to expand those. And this is one definition that is commonly used. And you know, in this definition, that really the responsibility for adherence is strictly located within the individual. And I believe that there's more to adherence than the individual themselves, naturally. That's extremely important. But there's a context within which they live that includes healthcare professionals, that includes families, it includes the society, healthcare system, et cetera, et cetera. My colleague, Dr. Reichert, gave you the 2014, she gave you a portrait of adherence. This is a bit of historical in terms of numbers related to adherence. So you can see that it is an issue that's existed for as long as we've talked about it. And we also know that the CF population is knowledgeable about medications. However, despite this, we continue to have issues related to it. Some of the barriers that we've learned from research related to adherence, I don't think that there's probably anything here that you've not seen or read about or been told before. Some of the consequences, and again, to reiterate, Dr. Reichert, what she has just shared with you. My program of research, in addition to my this study with CF, also I do CF or research in home care and safety in home care, and particularly from a medication management perspective. So not only am I interested in adherence in the CF population, but in the home care population in general, and particularly related to medications. And in the 2004 Canadian study related to adverse events in hospitals, the rate was somewhere around 7%, and one of the primary areas related to adverse events was medication. And so I was part of a Canadian group that did safety in home care study completed in 2012. And looking at adverse events in home care. And of course, not surprising, the rate there was between 10 and 13%, and medications were in the top 3, so medication related. And of course, adverse events, not only taking wrong medication, but not taking it, taking it too frequently, et cetera, are all considered to be adverse events. In the study that I'm doing, I certainly want to gather multiple perspectives. So as I already indicated, the adults themselves, whoever they indicate they would be beneficial for me to interview with respect to whoever helps them with their managing their CS. And of course, healthcare professionals involved in the care of those with CS. Methodology, I've already referred to, is grounded theory. And in the literature that I showed you related to adherence, one of the things that I noticed when I was looking at that adherence is often as researchers, we look at, okay, when we see that someone has conducted a study, we look at what theories, for example, when you come up with your findings, what sort of theories are there that help explain the findings that we get? And I noticed in most of the studies related to adherence, there was very little use of theory in terms of explaining what we were finding related to adherence. And so that's one of the flags that when there seems to be very little with respect to theory to be able to explain what we find, that perhaps we need to consider developing theory. So that was my motivation to entertain the idea of doing a grounded theory study, which means you actually build theory from the ground up. And you build it based on perceptions of the people that are actually living whatever your phenomenon is. And so myself and those participating in my study actually construct what actually comes out as findings. And as I mentioned earlier, what I'm after is what is the main concern of adults with CF in the whole management? What do they say is their actual main concern? And what is it they do about that? And when I come up with that, that's actually will be what the theory is made up of. And so my methods, I do interviews with all individuals involved. I do my analysis along with the interview process. So following each interview that I do with the individuals in the study, the interview is audio recorded, of course, at the time that it's done, transcribed immediately after. And then I do the analysis of each and every interview before I proceed to the next one. In the analysis process, as I do the interpretation of what the individual has shared with me, I come up with what I believe has come out of the interview and verify that with the individual that's participated in the interview. And the written transcriptions that I get back from my transcriptionist, I go through a process where every single sentence is carefully examined. I do a coding process. And in the coding process, I'm looking for what's the action or interaction in every single sentence of that interview. And most of my interviews are somewhere between, the shortest ones are usually 45 minutes, but most of them are a minimum of an hour, between 1 and 2 hours long. So we come away with a lot of data, and it probably amounts to 40 or 50 pages worth of transcription. And so as I code, then my codes are usually related to what's the action, what do I see going on in each and every sentence. And then I group these codes into what I call categories. And eventually, I'll probably have, from my experience from doing other grounded theory studies, I usually have anywhere between 12 and 20 categories at the end of my data collection. And then as the analysis, as I take it further, then those categories, eventually I come up with concepts, and usually 3 to 5 concepts that will make up the theory. The location of my study is in the 3 Atlantic provinces, Nova Scotia, New Brunswick, PEI. I'm based in Nova Scotia and Halifax. And so the really important part, I've done my data collection with the adults in the province of Nova Scotia so far. And so what you see here is, I remind you, very, very preliminary because I've not done my data collection with healthcare professionals in Nova Scotia, and I've not done any data collection in the other 2 provinces. So you see I have 6 categories to share with you today. And I actually have some illustrations from each of these, which will comprise the last 6, the remaining slides after this one. And so what I've been struck by in the data so far is the amount of work that individuals, that these adults have to do in order to keep going, to keep as healthy as they possibly can. It's astounding when I think of their adults, they're working, everything that they need to do in a regular working life of an adult, in addition to managing their cystic fibrosis. And so it comes out loud and clear in the data. The second one, which I call passing as normal, and this is probably something that you've heard or those with CF have shared with you. And passing as normal can, in terms, like one extreme example in the data that I've collected so far is an individual who has been in a partnership for, been married for probably about 10 years, and has shared that to date she is still not, her in-laws still do not know that she has cystic fibrosis. And Sunday dinners, of course, are important in this family, and it's a very stressful experience for her because, of course, she's already thinking that Sunday dinner, I'm going to be there late in the evening. I need to get up at 5 to be able to do my treatments and to get to work on time and so on. And so you can feel and hear and the stress that this individual is living. And it seems on the surface like, well, you know, isn't it simple enough just to let them know? And I'm sure that they would be happy to do it some other evening. But it's not as simple as how we might think it might be for individuals. And then some of the other participants, it varied who they may share it with, depending on how secure or how safe they felt, because they are adults, most of them in the workforce. And so in their work environment, they're continuously judging and deciding who it may be safe to share their diagnosis with. Number 3, living with an expiry date, and I use that term because it was actually used by a participant, and her earliest recollection was that I think probably around age 5, learning that she may not live beyond age 10, and then at 10, maybe not beyond 15. And so it's really quite astounding or striking when people share this with you, because living my life growing up, naturally, it's just automatic that you plan, you think ahead to what you're going to do when you finish high school, what you're going to do in terms of careers after that. And so to be almost robbed of that, and also learning or having this recollection of this expiry date is really quite a powerful statement. Fortunately, with the incredible progress in CF, there's lots of hope in the people that I'm interviewing, and the fact that the majority of people with cystic fibrosis are adults is a hopeful thing. Balancing work and CF, really, I'm sure that all of you can appreciate the balancing act, not only in terms of keeping up with work responsibilities, also the balancing act in terms of, you know, the workplace, who can I talk to about my CF, how is my boss going to be with this? And probably, I would say half of the people so far that I've interviewed, their work environment, they find their employer really quite understanding, flexible, and in other words, as long as you do your work, they're really quite how you do it, the way in which you choose to work. They have considerable amount of flexibility, which is really important, and hopefully we get better and better. Facing disease progression, when individuals talk about that and what they could do at a certain age, and now that I'm at this age, I've noticed some things that I can't do that I used to be able to do. So very preoccupying. And of course, testing the boundaries. And I was thinking about that when Kristen was speaking in terms of how often can I skip and be okay? Like, is there a dose of adherence that is the right dose? And I'm sure there isn't one size fits all, but I suspect perhaps we may reach a point where we actually could know or be able to find out for an individual how much might they do or not do and still have reasonable metrics in terms of how they're doing with their various body systems. So now I'll share with you some of the illustrations from the folks in my study. And so for those who fall in the category, or for the category of working to keep the body going, this is a quote from one of my participants. And again, about an hour in the morning and an hour in the evening. And I was just thinking, in terms of recreation time, like 2 hours a day that you're doing self-management related to CF, that can be lots of recreation for another individual. So passing is normal. And again, there is a range here, but most everyone, there were instances where they were reluctant to share their CF diagnosis. And for the, I put a couple here because a couple of illustrations, just because I found it quite profound, the information that individuals shared with respect to this notion of living with an expiry date. And for the second one there, and I was told, go ahead because you're not going to live to be 25 and you'll never have children. And she actually is well past 25 and she has children, so it's pretty exciting. And again, this notion of balancing work and cystic fibrosis and the increasing longevity, which is really exciting. It has led, of course, to career planning and training. And however, disease progression does pose challenges to a career. And for any career where anyone has a chronic illness, there's going to be challenges to that career. And of course, facing disease progression. And this one too, in my 20s, so they're clearly starting to notice what I used to be able to do and versus what I can do now. And testing the boundaries. And you can see this individual in the first one that I'm going to get to it, and I will get to it, but I'll do it my way. And one of, for people who use this methodology of grounded theory, one of the philosophies that underpins the methodology is the philosophy of pragmatism. And pragmatism was developed by an American, John Dewey. And the whole notion of pragmatism, the notion is that individuals will do what works for them. They'll find their way to what is it that works for me, what gets it done. And so I find myself in during the interview process that I'm thinking about that a lot, because, of course, what I'm looking for here is, okay, what's the main concern of these individuals and what is it they're doing? And so this notion of pragmatism, or pragmatically, what are folks doing, I think this thinking will help me, or will take me to a place where maybe I can come up with some concepts that perhaps haven't been coined to date. And then, just some concluding thoughts. Certainly within the interviews, unless I talk about adherence or non-adherence, it's not in the language of the people that I'm interviewing. So in terms of what preoccupies these individuals on a daily basis, they're not thinking, am I adhering or am I not adhering? It's about doing what they need to do to get through a day and finding their way to do it. And I think the other thing that I was struck by was how appreciative that these folks are related with respect to the healthcare team. I mean, they are so complimentary. They just can't say enough about the individuals that work with them. And this isn't something that it's not even a question that I ask. How do things work out with your healthcare team? I don't even ask it. It automatically comes up. And they're so willing to share. And the other thing is the awful guilt that they feel if they've not been doing their treatments as they've been told they should. And of course, they'll candidly share that if I know I have a visit in 2 or 3 weeks, a clinic visit, then they'll start being as adherent as they possibly can be, because they want to minimize the disappointment that they may feel or see in the healthcare team if things aren't so good at the time of their visit. So they really do feel a lot of guilt related to that. And my research funders, to whom I'm very thankful as well. Thanks, everyone.
Thank you, Dr. McDonald. I'd like to welcome Dr. Yves Berthiaume.
Good afternoon, everyone. I'm the spy in the room. They sent me from a salon été to make sure that you were all behaving. And the other thing is, I feel a bit awkward because, by training, I'm a pulmonologist. So I'm going to 2 things that I'm not an expert in. First is to talk to you about diabetes. So it's a bit strange having a pulmonologist talking about diabetes. And second, follow expert on treatment adherence. And I can tell you that I'm far away from being an expert on treatment adherence, but I want to tell you more about the work that has been done by a member of our CF research team, Dr. Lise Lamotte and Chantal Sylvain, who did a study. And what you will see, I think you will realize how interesting it is that some of the sentence or observation made by Dr. McDonald, it will be quite similar to the observation that Dr. Lamotte and Sylvain made here in Quebec. So, by disclosure, so I'm a consultant, or have received, our clinic has received support from Novartis, and we also do contract clinical research with different pharmaceutical industry. So let me start with a presentation, a case presentation. So this is a 22-year-old male with homozygote delta F508, so the classical mutation. His body weight is quite stable, normal, no change recently. His pulmonary function, as defined by the FEV1, is, we would say, moderately a moderate disease, but has also been stable for the last 3 months. There's no obvious sign recently of pulmonary exacerbation, no change in his cough or sputum. His X-rays is similar. His lab report are similar. maybe a bit of increased fatigue in the last few weeks and feeling a bit more thirsty. So this is a classical case of someone who comes in a clinic on a Friday afternoon, and you look at him and you say, well, let's do some blood work, and you do glucose, and you see that it's 31 for a normal of 6. So even if I'm a pulmonologist, that's a clear sign that something is abnormal. And in fact, it's a sort of a classical presentation that we see in the clinic of someone coming with first time that they really get in contact with diabetes. And the creatinine is elevated because he's a bit dehydrated, because he's losing a lot of water, because he's losing glucose in his urine. A second case, which is also quite classical, now we're seeing a 30-year-old young woman, also with delta F508 homozygote. However, she is losing weight, and her body weight is lower than what you want, or because you want to have a BMI around 20, and she's been losing weight despite her great effort, well, at least as she says, of trying to feed herself. There's no obvious sign, again, of pulmonary exacerbation, but her lung function is dropping gradually. There's no known sign of diabetes, and every lab work that we do don't give any sign of diabetes. However, for many patients, changes in body weight and lung function occur up to 2 years before we can make a diagnosis of diabetes. So this is another clear case of when we're sitting in clinic where we see these patients. The first thing we need to think about is there an appearance of a new bugs in the lung, new type of infection, or maybe the appearance of diabetes or other clinical condition. But clearly, we need to ask ourselves questions when a patient conditions evolves. So those were 2 cases of clear presentation that could be associated with CFRD for cystic fibrosis-related diabetes. And what I'm going to talk about this afternoon is first to give you a very rapid overview of cystic fibrosis-related diabetes. And then I just want to try to reinforce the point that CFRD, and I'm going to use the abbreviation if you don't mind, instead of saying every time cystic fibrosis-related diabetes, so we'll use the word CFRD. CFRD is not a classical case of diabetes, and I think that's a message that I want you to retain this afternoon. And then I'm going to go in the work that Dr. Lamotte and Dr. Sylvain has done in trying to understand how the patient perceives, and also how do we, in the clinic, try to deal with this new emerging problem that we have to incorporate in our care of the patient, is to deal with the diabetes. And finally, just general thought of where I think we should put our effort in the next few years. So this is a slide coming from the work of Dr. Antoinette Morin, who's really, I would say, the kingpin in CF-related diabetes in the United States. And you have at the bottom here different age, and you have a different column with different color. The very dark red is what we would consider a patient with normal glucose tolerance, meaning that they are like a normal person. And then the lighter red is what we call glucose intolerant. Now, glucose intolerance is a very arbitrary definition because it's based on a lab report. So what it means is if we bring you in the morning when you're fasting, we'll give you a load of glucose, and we see how your blood glucose goes up and down, and at 2 hours, we expect that the blood glucose will be back to normal. If it's not back to normal, we call you glucose intolerant. The start to the pink area is what we call CFRD without fasting hyperglycemia. What this means is instead of having your blood glucose not being normal, it's higher than 11.1. And that's been defined as a cutoff to call it diabetes. However, if you come the next day when you're fasting, your blood sugar will be normal, which is not the case if you're a diabetic. At fasting, your blood glucose will be higher. And so the whitish in last category is what we call CFRD with fasting hyperglycemia. So that's a classic case where you're higher than 11.1 and your blood glucose when you're fasting is abnormal. So you can see that with age, if you look at the young adults, 20 to 29, 77% of the CF patients have abnormal glucose metabolism. 77%. Now, when I started to work in a CF clinic, I can guarantee you that I never really realized that. But now this is a very important issue. And you can see that at age 30, it's not any better. And in fact, you can see that 35 to 40% of young adults become diabetic. Now, we could say this is just, abnormal blood glucose. Now, this has significant impact. This is also a study done by Dr. Antoinette Morin, and it's a prospective study, which means that the patient will follow, we're not looking at the chart backward, but we're really following the patient. And you can see at the bottom here the NGT for normal glucose tolerant, IGT for intolerant to glucose test, and then you have CFRD, no fasting hyperglycemia. And on the y-axis, or if you have the changes in lung function over a period of time, and the square is really the FEV1, which is the test we do in clinic most of the time. And you can see that the rate of decline is higher for people who are not diabetic, glucose intolerant, and if you're diabetic, your rate of decline is higher. So having diabetes or glucose intolerance has a significant impact on the evolution of lung disease. Now, what is becoming even more worrisome for someone like me is the next slide. And in fact, this is just a very recent study. If you look at the bottom, well, it's pretty small. It's 2015. In fact, it was published in March 2015. And this is screening for retinopathy. So you know that patients who have type 1 or type 2 diabetes, the major complications are renal disease, eye disease, which means that you have proliferation of microvessel on your retina, which can lead to blindness. And if you look here, this is CF patients who have been screened for retinopathy, and you can see at the bottom that 2 or 5% of that particular sample had significant retinopathy, which probably needed laser therapy. And then you have moderate 21% and mild 14%. That means that microvascular complication associated with diabetes, we're starting to see this in our CF adult population. In our clinic, we also lost at least 2 patients in renal failure because renal disease associated with the diabetes. So the impact of CF-related diabetes on CF care will be a big challenge in the future. And to put more icing on the cake, I guess it's not necessarily a very good cake, but if you look at the white bar and the black bar being the mortality associated at different age that you see at the bottom, so over 40, over 30, and 39. And the black bar are patients who are CF and diabetic, and the white bar are CF patients who are not diabetic. So there's an increase in mortality. In fact, we think it's about 3 to 6 times higher in CF patients who have diabetes. So the main message And I don't want to send a message of negative message, but I think we need to realize this is a significant issue and we need to pay attention to it. I wish I had the whole afternoon to try to give you more information on why do CF patients become diabetic, because I think this is a very challenging question, but I'm just going to show you one or two slides to give you what we think is the general idea. So here are, in fact, actual data collected by Dr. Rémi Rabaza in our team, who's an endocrinologist. So everything I say today, if I say something wrong, it's because he didn't teach me well. So what you see here is the plasma insulin level. So when we do the glucose challenge in a patient, we take blood sample, and you can see at the bottom here on the x-axis, so 0, 30, 60, 90, and 120 minutes. So those were blood sample taken at different times during the test. And you have the curve that is the highest. I'm not sure I see the color here, but the one who has the more bell shape, this is a normal response. So if I take any one of you and we give you glucose, you would have your insulin go up significantly in the first 30 minutes to respond to this challenging glucose. All the three lines under it are all CF patients, and no matter if they are glucose tolerant, intolerant, or diabetic. So that's why we say that, in fact, the basic defect for cystic fibrosis-related diabetes is a lack of insulin secretion. So what you see is what we would call the first phase of insulin secretion is definitely abnormal in CF patients. Now, this is a bit small, but I just want to put this slide because to pass two messages. The first one is we're still, I guess, trying to chase what is the best animal model to study diabetes in CF. And I could have presented Dr. Vincent Poitou in our team did work with the CF mouse, but it's a bit complicated, so I decided not to talk about it. There's now, as you know, a CF pigs that were raised in Iowa, and this is result also from a ferret, CF ferret, that are also raised in Iowa. And the main reason I'm showing this, and it looks very, very small, but everything that you see over the dotted line is the glucose in the CF ferret, and what's under are really CF ferret that are not CF. So that they are not, that they are ferret that do not have CF. And in the CF ferret that compared to the non-CF ferret, you see that the variation of glucose. And so the first thing, and if you look at the bottom here, is this variation in glucose appear as the ferret gets older. So there is two messages I want you to retain. First is it seems like even in animal model that age has a role to play. No matter if it's in the pigs, the mouse, or the ferret, as the animal gets older, the dealing with glucose becomes more difficult. Second message, for any animal, there's a lot of variability. Even before they become diabetic, dealing with glucose is very difficult. So it's not rare for a CF patient, before he becomes diabetic, to have a lot of hypoglycemia, or having spike of glucose and then return to normal. There's a huge variability in the way. So those are the two key points that in the future we'll need to understand. Is one, what's the impact of age? And second, why there's such a variability in dealing with glucose. CFRD is not type 1 diabetes and it's not type 2 diabetes. However, if we had to choose, it's probably a bit closer to type 2 diabetes. So why it's not type 1 diabetes, although the main problem is a problem of insulin, if you want quantity of insulin, which is the real problem of type 1 diabetes, is the main reason is CF patients do not have antibodies against their pancreas. And there's no genetic coincidence with what has been observed in type 1. However, there is evidence pathologically that if you look at the pancreas, there's some similarity with the type 2 diabetes. And in fact, if a CF patient has in his family patient who have family member with type 2 diabetes, his risk of becoming diabetic is greater. And finally, the same modifier gene, which means genes beside your CF gene, can help or put you at greater risk of becoming diabetic. You can find the same genes that are giving you an increased risk of having type 2 diabetes as CF-related diabetes. So once we've said this, how do we screen to find a patient as CF, and how do we treat them? So unfortunately, it's quite difficult to have an easy screening method. And what you have there is 1, 2, 3, 4, 5 different techniques that could be used to try to identify patients who are at risk of becoming diabetic. The first one is what we call the glycated hemoglobin. What it is that, when your blood glucose is high, you sort of add sugar to protein in your blood. And one of those proteins is hemoglobin. And because your red blood cell lives a long time in your circulation, then we can measure the amount of hemoglobin that has glucose on it as a sign of chronic changes of glucose in your blood. The problem we have is, in fact, it was one of the studies done also by Dr. Rabaza, is in CF patients, the turnover of hemoglobin is higher. So this 3-month period is really not true anymore. So it's a good method. So if a CF patient has an elevated glycated hemoglobin, it's abnormal. But having close to, I would say, the maximum normal value, that doesn't mean it's normal. It could be abnormal, so it's not very precise. Fructosamine is a different form of looking at protein that have glucose on them, and it also is not very sensitive. Fasting plasma glucose, I told you there's a lot of variability in CF, so it's not a very good method. Glycosuria, the same thing. If your blood sugar vary a lot, trying to find it in the urine is not good. I think one of the promise is what we call continuous glucose monitoring, and we are just starting right now a study on this. It's a small capsule that we put under your skin that you leave there for 3 days, and it records your glucose concentration every 5 minutes. So we can see the profile of a glucose variation over 3 days. And the problem we have right now is that there's no validated test on this. So that's what needs to be developed, which means that the only test right now that is really available is the OGTT, which means the oral glucose test. Now, the problem with this test is, first of all, is you need to come to a hospital fast. So you didn't eat. It takes 2 hours. So ask a CF patient could come at 7:30 in the morning, not take breakfast, take his glucose test for 2 hours and not eat for another 2 hours, and then come to the CF clinic to wait for the result. And you can imagine what the adherence problem we have in doing this test. In fact, we have a very large no-show or no-call. You wait in the morning and the patient doesn't come. So how do we treat? Again, we could talk a long time, but for the moment, what would be the best treatment for CF is insulin. And why? As you see here, the blue bar is decreasing as the patient becomes more diabetic. There's less insulin, the glucose goes up. And it's quite clear in a patient who has CFRD, so cystic fibrosis-related diabetes with abnormal glucose when he's not eating, that he needs insulin. It's almost as clear in someone who has CFRD without fasting hyperglycemia, and we really have no idea in intolerant patients if we should start insulin. So why insulin? Well, first of all, to avoid the complication I talked to you, the retinopathy and renal disease. Second, clearly in a patient who has CFRD and we start insulin, they pick up weight. That's a big thing we observe. Most of the time we observe a stabilization of lung function and a decrease in infection. The problem is we really don't know when to start, which patient to select, and what's the optimal regimen that we need to use. A picture is worth 1,000 words. So what you see here is therapeutic adherence of a group of patients who were started on the first year after you start a therapy. And each line represents a patient with a different color. And 100% is at the top and 0% at the bottom. And you see 12 months. So you can see that the adherence of patient to any therapy in CF is at least, we can say, hectic. So why is it so difficult also to obtain this therapeutic adherence in the CF? And that was the purpose of the work that Dr. Lamotte and Dr. Sylvain did. We tried to identify what we would call the barrier. And I would just like to start by stating a bit the problem, and as you see here, so my appointment was on such a date so that I would call and say I cannot come. I didn't feel like seeing them, especially when I wasn't feeling well. I wanted to avoid having them tell me that I have a problem with glucose. Or that's a statement for a young patient, and the other statement is coming from the endocrinologist. They never do their blood test for diabetes before coming to see me. They do them on the day they come to see me. So I cannot rely on them. It doesn't have the result. But most of them do not bring their blood glucose diary, and they don't check their blood glucose at home. I'm supposed to adjust therapy, then act on blood sugar level while I don't have any parameter on which to base my decision. It's not easy, and it started to laugh. That's a usual clinic visit to an endocrinologist. So we do have a problem. However, the problem doesn't necessarily reside only on the patient side. And we had this very important debate in our clinic on who should manage to do the screening. Should it be the CF team or the diabetes clinic or the clinic that take care of diabetic patients? And we had multiple meetings of the two teams together, and this is a bit of summary of how we see things. And as you can see, they're seen quite differently. For us, diabetes is a complication of CF. For the diabetic team, it's a distinct disease. For us, we approach this in the overall care of the CF patient. For them, it's diabetes. Let's treat diabetes. We don't care if the patient has whatever other condition. In our clinic, the clinic CF nurse really has multiple role and function. In a CF diabetic clinic, you have the nutritionist, you have the nurse who tells something, the nutritionist says something, the psychologist says something. At least they're lucky they have psychologists. We usually don't have them. So the approach to care is very, very different. The work organization is very different. Our care is individualized. their care is standardized. You're insulin, this is the care we're giving you. You're on hypoglycemia, this is the care we're giving you. You're intolerant, this is the care we're giving you. You come unpunctual, we follow you on a regular basis. They only take you on appointment, and so we, are continuously available. Teaching is very different. We have a very individualized teaching. It's only group teaching. And can you imagine putting a CF patient with a type 1 or a type 2 diabetic patient who's 50 years old, who's obese, and trying to teach each of them the same approach to diabetes? It doesn't work, especially if you do this at 8 in the morning. So there is a lot of different mentality between the two, and it took a long time before we sort of came to, I would say, mutual agreement on how to deal with this. And I'm going to skip this. So let's talk about the patient dilemma. So this is exactly the same type of study as Dr. McDonald showed you. This is what we call a qualitative study. It involved 39 patients who were from 6 different clinics in Quebec who had interviews that were then transcribed, and Dr. Lamotte and Sylvain tried to extract what were the main messages. And they identified 3 specific dilemmas for the patient. The first one, CFRD, is it a complication of CF or a second chronic disease? So this is a statement from a 32-year-old young woman who had CFRD for 11 years. Although I don't feel that diabetes is a second disease, I also cannot group them together and compare them. They are 2 different things, but they are both associated with the same health problem. So you can see that it's not clear in the mind of CF patient if diabetes is part of CF or is it? CFRD requirement. I'll successfully add more daily technique. Even if my blood sugar device is on my desk and in plain sight, it seems that my brain doesn't see it the same way that I see my enzyme bottle. So for them, for most of them, I would say, because it comes later in life, so I'd like to try to introduce a new routine that's something that is it or isn't really part of CF. So it's easier to just toss it apart because they don't, they've been trained that, you have to take care of your lung. This is very important. But your blood sugar, well, okay, maybe it's higher. In fact, it's very interesting. There's CF patients who get so used to have a high glucose level. And, it's not abnormal for a CF patient to come and his normal glucose level would be, let's say, 12 or 15. And when they really work at it and bring back their glucose to 6, they feel hypoglycemic. They lack energy because it's like the system is totally shifted and they are not used to have a normal glucose. So they feel weak, no energy. So why should I decrease? I feel worse when I have a good glucose level. Nutrition. Look at this. From the time we are born, nutritionists always tell us, eat and don't worry about what you eat. So I never pay attention to what I'm eating. The idea of having diabetes and having to calculate calories and watch what I eat is something I would not like. This is what a CF patient is thinking if she does get diabetes. And the challenge of calculating, in fact, if any of us was trying at every meal to calculate your carbohydrate and decide the amount of insulin you would give yourself, it is a big challenge. And when you're used to just eat whatever comes and not, worry about it, that's a big change, and it's not easy to incorporate. Why worry about the long-term consequences when facing a life-threatening problem? So I have somewhat ignored diabetes because the repercussions are longer term. Even if I don't inject my insulin this evening, for example, my blood sugar would rise, but I would only be dangerous in the long term. Whereas if I don't do my cystic fibrosis treatment tonight, I will have repercussion will happen right away. So they don't perceive the risk of diabetes as being important because they don't expect to live longer. But that's not true anymore. So I think what I've learned from these things is, first of all, we have a lot of work to do ourselves in the clinic because we haven't yet found the best way to approach screening, to incorporate it in a manner that it will be practical for the patient and for the clinic. And until we do that, I think we'll be meeting a lot of challenge to do the simple oral glucose tolerance test. And I return to what Dr. McDonald also said. We always want to have what we call in medicine the evidence-based medicine. You know, you do things because it shows to be efficient and good for. But I think we need to think not only how good is a therapy to influence outcome, but how this therapy fits in the way the patient treats itself. You could have the best therapy you want. If the patient is unable to put it in his normal life, it won't work. So I think we need to go beyond evidence-based and include in evidence-based also the practicality of the therapy. And I think one of the problems we're facing right now in CF is the only thing we do is add on. You know, we're adding a new therapy. We're adding this. We're adding pulmozyme, hypertonic saline, azithromycin, insulin, new medication, new nebulization. I think we need to start wondering, well, is there a way maybe that we can structure therapy, redesign it, so that it becomes practical for a patient to really do it and yet have the best outcome? And I think, you know, one of the problems we're facing a lot in CF clinic right now in Canada, especially in adult clinic, and I can only speak for our clinic, we have very little means to deal with the emotional needs of the patient and to talk about this. You know, if we could find a psychologist in a clinic in Quebec, in an adult clinic in Quebec, wow, that would be a dream come true. No, we're not taking care of that problem right now. We're just sweeping it under the carpet. And in fact, if you look at it, this is from the guru of evidence-based medicine, Dr. Guyat in Hamilton, who really is the one who's been pushing for this. And look at his sentence: evidence-based medicine doesn't make decisions, people do. So I think, you know, we can come with the best therapy we want, but if we cannot incorporate it and make people adhere to it, it will be very difficult. And if you look at all the blue circle here, you know, you have the patient preference and action, the evidence-based experience, so that's the best therapy we can design. There's the clinical context, and you have time there. It changes with time. And that's another aspect. What is good, or how we can incorporate the therapy when someone is 20 years old versus 40 years old is different. And we need to consider this, that time is an issue. And in fact, I think that's where the clinical expertise comes in. And it's something that is not palpable. You know, it's not something you can touch or measure at this point. But how, as a clinician, you need to think about all these issues, incorporate it, and not only take one of them, but all of them when you take a decision with a patient, not for a patient. You take a decision with a patient. So my conclusion is, first of all, The cause and impact of CFRD are not completely defined. I think we still need a lot more basic research to understand why a CF patient which is intolerant, doesn't have diabetes, and the same amount of insulin when he's 20 years older, then he becomes diabetic. It's still, the amount of insulin he secretes is not any different, but yet he becomes diabetic later. We always talk about insulin sensitivity, but it's more than that in CF. It's not insulin resistance. So there is a lack of knowledge here. Second, what is the best treatment and screening? We have a lot of work to do in clinical research to identify better screening method that will be better adapted for the patient's situation. What is the place of insulin therapy? Alternative therapeutic approach, exercise and nutrition. And I did remove it, but we did a very interesting study regarding exercise and glucose intolerance in CF, and I think it's a very important issue. And we need to do a lot more work regarding the additional burden. And we need to do more knowledge transfer. I think education to the patient, for sure, psychological support, and adaptation of the clinical care to the patient reality, I think is very important. But above all of this, I think what we need to do is providing hope in a positive image. I think for a long time, and I've been depressing at the beginning, telling you, that diabetes is a bad problem and all this and all that. But how am I going to convince a patient to invest in his therapy if the only image I'm giving him is the route to transplant? So I think we do need to work on a positive image. And I know that all of you recognize on the right-hand side Lisa Bentley, which I think is an important role model. I mean, she has, I would say, worked her way through CF in very different ways at different time of her life. And we really need to demonstrate to CF patients that they can live a relatively normal life. And we need to stop telling them that the only thing that they will end up with is a lung transplant in a bad life. And maybe then it will be easier to convince them to adhere to significant therapy. So I just want to so this is the CF diabetic research team that we had at the University of Montreal. Unfortunately, on this picture, Dr. Lamotte and Sylvie are not there, but that was our team from a grant obtained from the CF Foundation, and we were able to do research work. I didn't present on the CF mouse and the cause of diabetes in CF. We did work also on the impact of inflammation in lung disease, and presented to you the work of Dr. Lamotte on the screening. On this, I would like to thank you very much for your attention. Thank you.
This has been a very interesting session. Thank you so much. I'd like to extend the thanks on behalf of all of us to Dr. McDonald, Dr. Reichert, and Dr. Berthiaume for taking the time to present to us today, for coming here, and for your dedication to the CF population. Thank you very much. Small gift of thanks for each of you.